numb them up, then you can start working. And then you got to make a decision. And if you're not sure, call somebody. There's nothing wrong saying, you know what, I'm not sure about this kid, a little bit different, right? A million different scenarios. This tooth cracked, this tooth didn't crack, this tooth got hit, this tooth got a crazy line. It's all different. So you got to treat each tooth differently. Yes, question. Immediately. Not in this case. If it's not mobile, you're not splinting it. If you can see the teeth that others are not moving and this one's moving, you got to splint it. Here, in this scenario, nothing was moving. So if nothing moving, I'm not splinting it because there's no reason to. So buccal plate present, no probing depth. You're probing too. You push here, she goes, ouch. You probe, it goes all the way up, it's cracked. You see this if you don't have a CBCT that day, right? Because you're gonna probe and see where you're at. And then you're following up, that's your follow-up. So when do we make the final restoration? The question is, when do you make the final restoration? She has no pain, no sensitivity. So now, what are you thinking? Who's been practicing the longest? Peter. What are you thinking here? No exposure. Remember, it's fracture, no exposure, fracture, exposure, two different trees. Fracture, we're going to talk about that. Fracture, exposure, fracture, no exposure. AJ? No, what are you doing? You got to do something. You can't leave her like this.
Oh.
Are you doing the root canal?
Not immediately.
No. There's no root canal here, ladies and gentlemen. There's no endo here. There's no pain, no sensitivity, no pulpal exposure. You're not doing endo. You're not. If you want to split, you can, but you don't need to. There's no mobility. So what are you doing, AJ?
Well, additional restorations. I'm going to evaluate over time.
Your clinical assessment. I know what's the treatment though. We have to now. We know the diagnosis. No pathology, nothing like that. It's okay. Clinical assessment, soft tissues, okay. She didn't fall and hit her lip and cut her lip, right? So there's no external hit. It's just a lower teeth went bang into the upper teeth. Okay, you got to check the lower teeth too. Tooth position, fracture type, is it enamel, dentin, pulp, is it exposed or not? Mobility, like I said, there isn't. Percussion, there isn't. Color changes, yes. Right? Another thing is, if she was 22, would you change your treatment? If she was 79, would you change your treatment? Guess what, ladies and gentlemen? Age is a big factor. She's 22, it's a different treatment plan because I got to think about next 60 years. If she's 79, I'm not really worried about it too much. She's right in the middle, 49, okay? So age is a big factor, especially on the pulpal exposures. When you have a pulpal exposure, that's a different animal at a 15, 20, 30, 40, 50. So age has got to be part of your decision. Okay, so let's go. Enamel dentin, no pulpal exposure, treatment. Repair, immediate dentin sealing, right? You're going to seal as much as you can. You're going to bond it as much as you can. In this particular case, we're going to do a little bit of gum surgery just to clean up the area. And where is the fracture? Is it at the edge of the enamel? Is it at the root? This case actually split. She actually had some, like a bonded crown, half a crown. So when she hit it, that piece came off and her tooth was left behind. So I'm looking to see where the fracture up here, the part that hit. And it happened to be just at the CEJ. And if you probe 3 millimeters and the buccal plate's there, that's a good sign. If you break up to the bone level, sometimes you can't see it on the x-ray. That's where you take a CBCT. Where is the crack? Oh, it's beyond the buccal plate. It's in the PDL. Now we need crown lengthening if we're going to save the tooth. And that becomes a harder decision. If it's broken, sometimes a premolar is broken all the way up on the lingual root, right? You have the buccal roots there, but the lingual is all cracked all the way up there. Can I make a crown on that? Or if I do, I got to do major crown lengthening. And then you start making a decision, do I take the tooth out? Because I can't restore it all the way down there. The crack is too far down on the lingual. So again, there's so many different scenarios. So if you look at it from the occlusal view, we do a little laser, get rid of the tissue. This is Dr. Ari, sent me this since December this happened. As a long-term patient, 20 years she's been with us. So that's what it looks like from the anterior position. Again, we take our photographs from behind because that's when you're always working. I want you to have your mind when you're working, not so much aesthetically, but when you're working, what are you doing? Take that laser, take it away. That's all dead tissue. It's all keratinized tissue there. See it? So now what? Well, I could put some bonding on. I could put a provisional on. Let's see what else. So he starts kind of, there was a thin, unsupported enamel on that side. So he takes that away. I don't like the angle of that. Can I do something to the teeth here to kind of build it up a little bit? So at least I have a good prep. So he does a little bit of a enamel, like little grooves in there, and puts a nice core material there. Okay, now she's numb, but she's not really feeling anything. Then he puts some provisionals on, makes some provisionals, clean it up, and now you got to let it heal. Here's where the big mistakes happen. And I'll tell you my first one when I was maybe 3 years out. It was with a single tooth. Lady came in, she was maybe 28, 30. Same scenario, no pain, no sensitivity. I put a provisional on, looked great. She's so happy. I let it heal for 3-4 weeks. She came back, everything healed. No pain, x-ray's good, no endo, clean. All right, tissue's healthy. My brain was, all right, we're going to make a crown. Take an impression, take the temp off, take an impression, another 2-3 weeks, put the crown in, color was a little bit off, come back 2-3 weeks later, got the crown perfect, aesthetic was great, cement the crown. Yay, we did it.
How long was the September bond?
1 month for post-op, and then 2 weeks with another one, so 2 months maybe.
Please repeat the question.
The question is, how long was she with the provisional? So she was with the provisional 2 months total. Right, well, I don't know that. I just came out of school. There was no Instagram. There's no ChatGPT. I'm thinking I'm making a crown. She's healthy. She's fine. She's not in pain. I made a crown. 6 months go by. Hey, doc, I'm feeling something. Take an x-ray, PAP. Oh, no. Send it to the root canal guy. Root canal makes a big hole. His drill was too fast and the burr was too old. Cracks my porcelain crown. Does the endo, says, oh, doc, I'm sorry, I broke the crown. Okay, we didn't have Luxatent back then. We had acrylic. She runs back to the office. I make an acrylic temporary, which looks horrible. I don't have a stent with me, because that was a year ago. I have to redo the crown. Who's paying for the crown? Can't charge her again. See, not even a year ago. I got to eat the crown. There's my time again. Match the color. The color's not right. The second time, third, fourth visit, 5 visits. Another crown goes in another 3 months. Whew. Okay. 2 years go by. What happened to that tooth? It's the first lesson of the day. What happened to that tooth in 2 years? Endo tooth, anterior, class 2 bite. No. It moved. Ready? Your first lesson today? The teeth. Are you writing it down? You should be writing this down. Put it on your wall. Go to sleep with it. Make a neon light. Teeth are moving. Forever. Teeth are moving. They keep moving, especially endo teeth. I would say 50% of them move about 1 millimeter every 5 years. That's why you see crowns, and every now and then a patient comes in, they got one crown in the front, and there's a big black line there, and you're like, oh, that dentist was terrible. You couldn't even hide the black line. No, the tooth moved. Tooth moved. It was perfectly fine. I've seen cases, my own. Perfectly fine aesthetics. Tooth moved. Tooth moved. She chipped the crown. I got to do another crown now. What's the lesson now? After I've just told you that. You gotta wait. You gotta wait. You gotta wait. You gotta wait. Just wait. Leave the temporary, evaluate in 1 month, evaluate in 2 months, evaluate in 6 months, wait. She looks fine. She's healthy. It's not falling off. Everybody's happy. The tissue's healthy. 6 months, maybe you want to take it off, reline it, reline it, get it back into position. Wait a year. In my book right now, it's a year. I don't touch this tooth I'm not making final crowns. No way. Because I've been burned. Don't make the same mistakes I made. Okay? That's the lesson on this case. Yeah. They were not endo-treated. Have not. I don't know what's going to happen in a year from now. She may get a PAP area. She may get movement. May break again. Maybe there's a fracture that I can't even see, and she bites down, the whole thing comes off. You don't know. As much as diagnostics that we have, you have no idea. It's happened to me. Oh, everything's great. The X-ray looks great. The CBC looks great. Okay, put the crown in. Crack. What happened? There must have been a crack. You see a nice, perfect little crack that I can't see on the X-ray. Yeah.
Another thing you could say to the patient, and what happens is, even though this looks great today, this is always a compromised situation.
100%.
Always going to evaluate.
100%. You must disclose to the patient that you have a complication right now that you can't predict. If you say that from now to the rest of your days in dentistry, you're going to be so safe.
And they expect it to happen.
You told me, doctor, you told me this was going to happen. Listen, it looks great right now. I can't see anything. Tell him the truth. You're just telling him the truth. I can't see anything right now. It looks fine, but we don't know what's going to happen in 2 or 3 or 5 years. Now, if it happens a year from now and I put the crowns on, and then she gets a PAP in 5 years, not so bad. But I waited that 1 year, right? I waited that 1 year because I gave him a chance just to see what's going to happen. My gut feeling in this case, she's going to probably be okay because those roots are really receded. Those roots are tight, strong, ankylosed. I think she's going to be fine. But I'm still not going to final crowns. That's my, yeah. Yeah.
A lot of the time, the reason why you see that is because one of them is ankylosed.
Right.
And the other one has normal.
Right. Right. And then when we go back to the moving part, there's another piece of the puzzle that I always want you to ask the question. And this time, when the accident happens, it's the time to ask the question. When you were younger, did you have orthodontics? You got to ask that question. That's like my first question out of any consult. Oh, hi, I want to do aesthetics. I want to do implants. I want to do this. Did you have orthodontics? Oh, yeah, I had it when I was 15. How many years did you have it? 2 years. Oh, and then I did Invisalign when I was 30, and now I'm 60. The teeth are going to move. And she doesn't have a fixed retainer. My orthodontist has a fixed retainer on everything. I know the teeth are going to move. Okay, so that's another piece of it. She looks great. She's happy. She got teeth. She's good. She's comfortable. Go. See you in 2 months. See you in 3 months. See you in 6 months. See you in a year. Again, go back, reline it. I have my sheet. I have a whole follow-up sheet in my office. It's about 5 pages I keep adding. Follow up this guy 6 months. Follow up, put it in your note, put it in dentry, whatever. 6 months from now, I put it ahead. Note, follow up, Carol. Anterior teeth, 2, 8, and 9. You've got to follow up. It's your responsibility. If you ignore it and just wait for them to come in, they ain't going to come in. So it's your responsibility. Okay, questions on that case?
You think making a crown is more traumatic to the two than...
No, I don't think it's a trauma situation. I think it's just a lot of time invested. That's something that may break and have to be redone. I don't think it's doing trauma to the tooth. If I make a perfect crown, I think it's doing trauma to the tooth. The question is the crown doing trauma? No, the question is, I don't know what's going to happen to the tooth. And therefore I wasted their money, my time, trying to get a perfect tooth that now I got to do endo through it or I got to take it out. That's the worst. When you get internal resorption, external resorption, a year later, 2 years later, you got to lose the tooth. Wait a minute. Crown, endo, perio, ortho? Oh, no, we got to lose the tooth now. Oh, you mean I got to start over with an implant on an anterior front tooth? Well, that's another $10,000 and another 2 years. Why did you put the final crown, Dr. Dean? I just wanted to finish. I got to pay rent. So 1 year is a good number. It's 9 months, a year. If everything looks good, okay, finish the tooth, and then let them know. High risk. Don't bite into apples. Don't bite into all disclosure. Can't guarantee anything. No guarantee. How long is it going to last? Oh, no guarantee here. I don't know what the heck's going to happen. Retreatment, endo, PAP, fracture again. It's a compromised tooth. Sorry. The sad thing is, when they're 10, 15, 20, they got to live the rest of their life. I have 4 of those. And one of them is my best friend's kid that got hit this way We thought it got evulsed because he was bleeding. It's snow time. It's like, I don't know, December. In the backyard, there's snow. And we're trying to find the tooth because nobody can see that. I took a picture. They took a picture, sent it to me. I go, you got to find the tooth. This kid's 10 years old. Guess what? They hot water the whole backyard. Never found the tooth. I said, put some tissue inside the socket and let me see it. The tooth was in there. The whole neighborhood is looking for the tooth. And it's in his mouth. Now I got a bigger problem. It's better when it falls out. This has direct hit into his freaking sinus. Hi, it's the night before Thanksgiving. Is the surgeon available? Dr. Dean, it's 7 o'clock the night before Thanksgiving. I can't come out. All right, see you Friday after Thanksgiving. Numb up the kid, go get it, pull it out, stabilize it. Disaster. The kid lost the tooth within a year. So all these things happen. You got to make the right decision. Okay, this is...
Wait, Dr. Dean.
Yes, question.
Do you charge them only for the build-up and the provisional, or do you charge the full fee, and in case the tooth fails, what do you do?
So that would be an emergency fee, a build-up, minimal, and a provisional fee, not a crown fee, provisional fee. And I usually add in a couple of post-ops. So let's say 2 post-op x-rays, just add it in the beginning, and then they get their free post-op, which is just an x-ray and just a follow-up. All right, now if they come to the 9-month period, they're okay. Take off the temp and start making the final crown. And they'll pay for the crown. Good question. Any other questions? Okay, that's Carol. This is Christina. Now she's 23 years old. This is COVID. That was last month. That was back in November. This is COVID. 5 years post-op, I'm showing you now. COVID, nobody's working. Everybody's riding their bikes and their carts with no hats and no helmets. I must have gotten about 14, 15 trauma cases, kids falling off their bikes and cracking their heads, cracking their teeth. And she called the office, accident, lip laceration, nose bleeding, concussion, pain is high, apical pathology everywhere. Everything's wide in PDL, sensitivity off the charts. She's super sensitive. Now, here's the good news. Younger patients heal faster, but younger patients have a lot more time. Older patients heal slower, but they don't have, they're 50, 60, 70, they don't have, it's going to be faster for them. But the younger people heal faster, but they have so much more time to, more mistakes, more hits, more trauma, right? You get hit when you're a kid in college and all that kind of stuff. Pain on percussion. The CBCT is okay. Buccal plate was still there, which was good. No probing depths. By the way, if that buccal plate was missing on number 9, I'm going to prepare her for an implant soon. If you have endo and a buccal plate that's missing on an accident case or fractured, you're going to probably lose that tooth. I would make a provisional. I'd wait a year. If it's perfect, maybe I would make a final crown, but I'm probably not going to make a final crown there. Yeah.
If the book players develop predictable with that implant, it'd be better to do a bridge.
So the question is,
Question,
yeah,
please.
the question is, the buccal plate's broken. How predictable is that tooth going to stay for an implant later? Great question. So now you got to balance. Is the buccal plate broke over here? Is it here? Is it here? Is it all the way up here? Because if it's all the way up here, they're in a lot of pain. And even then, I would splint it, let the bone heal, because you don't want to take the tooth out right now. Even though you lost the buccal plate and it's wiggling like this, 22-year-old, splint that baby, do the endo, tell her it's not going to be forever. I just need to stabilize the patient, let the body heal. The body will heal. How it's going to heal, we don't know. But 6 months from now, maybe I lost the buccal plate, but I have much more controlled environment. Take out the tooth carefully, put a bone graft, put a tissue graft, make a provisional. I have control. There's no control right now. Everything's moving around. You can't make final decisions right now. So stabilize the patient, get the endo done ASAP, splint everything together, bond the teeth, cross your fingers because you don't know what's going to go. The best scenario, there's no PAP and she's doing great. Worst scenario, 3 teeth get internal resorption, you're taking out 4 teeth. That's the gamut and everything in between. So again, be patient, splint immediately, do the endo right away, bond the teeth, stabilize the patient, and then the other thing is occlusion. When you're doing a splint, you have to evaluate. Can you see the tooth there, Doc? Want me to, should I just zoom in or something?
Yeah, you have to zoom in.
Oh, you're too far away over here. Is that better?
No, gotta,
Doc, pick up the camera. Can you see that? Right there, right
yeah,
there, right there.
that- yeah,
Okay,
that's
perfect.
better.
Okay.
No, it's not better.
What happened? See that good?
No, it's zoomed
dropped?
out again.
Where's Raul? IT. IT.
While you're waiting, what's your preferred method of splinting the teeth?
I'm going to refer to Dr. Salzer.
Number one choice, actual brackets and wire on the lip.
Brackets and wires on the lingual,
Labial,
labial.
because you don't want, you're about to talk about inclusion. The biggest problem, and the number one thing you look at first, is the patient can't pose, because usually the trauma is pushed deep
It's
in
moving up and down. It's like we want to zoom it in a little bit.
lingual, which would further interfere with their closure. You have to clear the bite, which sometimes you need to get the movement a little bit.
Right.
Get it out of the way. So
We want to get it closer to me.
Labial.
So I'm getting to the occlusion, which is what we're going to get to Dr. Salzer in a second. If the bite, in her case, her bite was a class 2, so she was a deep bite. Her incisors was over here. I had plenty of room. Okay? Class 1, any occlusion over here, you're going to the facial. And they're going to bitch and moan. Oh, I'm better. 22 years old. There's no other option. You can't get a brace back here. But I had a good clearance. I got lucky. Sometimes you get lucky, and I put it in the lingual. All right? So the answer is, you got to splint them. Where's your bite? Because you cannot have occlusion down there. And sometimes, even if you're hitting at the edge over here and you splinted her nicely, and she's hitting the cervical of the tooth, no good. Occlusion will kill every case. When you do endo, take it out of occlusion. This is pressure from percussion on the PDL. Doc, you did the endo 3 weeks ago. Why is it still hurting? Oh, you're hitting it. Take it out of occlusion. But then I'm going to lose my tooth. Well, it's tooth or pain? What do you want? And healing, by the way. It won't heal. If you keep doing this to the PDL, it'll never heal. You got to get it out of occlusion. Come back and do the restoration later. So this, you better have no occlusion. I mean, you got to check it like crazy. Blue paper, it's got to be slipping through. Double blue, it's got to slip through. Close tight. Double blue's got to slip through. I don't want any contact at all. That's centric. Oh, then they come forward. Ow. Well, you can't do that. An amyloplasty to lower. You can't have them hitting. You follow what I'm saying? That's going to cause pain and not healing. You want everything to heal. Don't touch it. Don't eat. Don't do anything. So Dr. Dean diets. Don't eat. Can't eat. Because you're going to hurt things. You're not going to heal. So listen to this. She posted this.
Yeah. Oh, yeah. Got on my tooth. Hey guys, so I'm gonna remove my, toothless.
It's before I even saw her. That's the surgeon who sutured her up. The mother's laughing at us. Tiger King.
there are a couple of shots in right now, and a root canal, and 2 new.
The one thing about Christina, what a great attitude. She just lost her teeth and she's posting. How many 22-year-olds would do that today? I mean, incredible. That's what she posted. So there's the splint. I put the splint in right away. I checked the occlusion. I thought I sent it to Lloyd. I can't remember if Lloyd did the root canal. You don't remember her? All right. Well, somebody did the root canal. Maybe it's me. I don't know. It's not that good. I don't know. Not good at root canal. So that's what it looks like. We bonded her. Clinical assessment, soft tissues hurt, tooth position. Now, another thing about tooth position, sometimes when they hit it and it goes in, sometimes when you hit it and it goes in or they hit it and goes out, you have to numb up. Now let me ask Dr. Salzio, are you supposed to put it back in position and then splint it? Yeah.
First of all, they'll help the occlusion and the compose, and then if it does get ankylosed, they both.
Right, right. So the protocol, and I thought this was true, but I wanted to always check my ortho, is push it, numb them up, push it back, or push it out, because sometimes they get locked this way and they can't close. Right? You got to get it back into position, splint it into that area, and then check occlusion, and then do the endo. Yeah.
You know,
Yeah, and then they splint them. They splint them like this. Yeah. Yeah. That happens a lot too. Yep, that happens a lot too. So percussion, sensitivity, all that stuff's happening with her. Radiographically, take the photo and the X-ray at 2 different angles, so you can see if there's a fracture. Something with a PA, you don't have a CBCT. Take another angle of it from the side. The X-ray from the side to get another angle of it, and then look at the occlusal view and see the plane that's actually like a nice plane. It's not out of position. Sometimes 2 teeth are out of position or this way, and you're not sure. They're moving, you got to kind of push them back in position and look at the CBCT. So if the pulp is exposure, we have to do endo. This pulpotomy thing is not a good deal. Just get it out, especially when they're past that 17-year-old situation. Youngers, it's a little different. I don't know what the protocol is on a 10-year-old. When they have pulp exposure, do you do the pulpotomy and leave the root so it closes when you have open apexes? I'm not an expert in that. I never really had only 2 or 3 of those, but I know for an adult, get the endo finished. Question in the back.
Joe, few. How long do you wait after splinting to do the endo?
No, right away. This is an exposed root. You have to do it right away. So if you can't do it yourself, at least the first 2-3 days, get it, because they're hurting. Remember, they're exposed dentin, they're hurting. Get it done as soon as possible.
And Dr. Salzer, what wire would you use?
try and use passive wire if you didn't like hand set them up, because you really don't want to put pressure on them. So
Passive wire.
passive, you want to try and like just make it bend to the way they're bent. You didn't move them by your hand. So maybe something like an 01-6 stainless steel.
0116 steel.
That you
I'm just repeating so they can hear. 0116 steel.
did.
Doesn't have to be really thick,
You
right?
do not want to.
Yeah, because then it's going to bend back and have pressure on it.
Right.
Right. You want a passive wire.
It's where you think it should be.
It just be,
passive.
yeah, passive right there. That's why I personally like Rib-On, because it's easier. I can just bond it on there wherever they are, and it just sits there and stays. And a lot of composite, the tongue gets upset. I don't care. I got to bond it in position. But the bite is the most important thing. So if your bite is in the way and you can't get a wire on, facial band. Invisalign tray is not going to work. I've had that. Oh no, I just put my Invisalign tray. It's going to be fine. No. You gotta brace them, splint them.
Few more questions.
Yes, go ahead.
Would you consider putting stops on the posterior teeth
Give me the water.
to disclude
Just a
the
regular one.
anterior teeth?
I do that because I'm not going to grind your guys, the teeth that you people are working with. So I'll adjust the occlusion a little bit, but I put on little turbos on the lower 6-year-old on the first molars, on the buccal crust, just occlude them a couple millimeters, just for those teeth while the initial trauma is healing. Miraculous.
Great idea. I never thought about that.
Because
If we
before
cement,
you,
I'll send it to you.
I'm using my phone,
Tell everybody,
my
which
iPad.
It doesn't allow, very soft, it wears down gently.
It's like the old stuff.
Yeah, and it's see-through, it doesn't bother them, but it just disciplines them enough that it's the right strength.
How long will the show?
Sometimes longer than that, but in 2 weeks, you can see everything starting to sort itself out, you can lower them a little bit, and then it's not traumatizing it over and over.
What's the most you can leave that in for?
Oh, months.
Oh, okay.
Ibuprofen,
Right.
Shoot check.
Well, does that mean you have to do it on all the teeth?
I just do it on the lower 6
Yeah, but then sometimes the other teeth start moving.
It's just some promotion.
But it's very unlikely that things are gonna
Right.
close down.
In 2 months, in 2 months is very close time. So, any other questions?
So I will just how there. So you can have open outlets, like nature, like
Yeah.
or teeth, so you
Yeah, like until 9.
I think that I remember that being the protocol in school, right? It was like if the apex is open, just do the pull bottom.
It depends also on the region, like very close mouth versus you have to add it's false, right? But if you see like a layer of dentin, so
No, if there's a layer of dentin, usually
depends there how old the patient. So if also you can see like open outfits coming to some of it.
yeah. So I started bonding on the upper left there, my second kind of polish, and then I finally got it to this point where she's just bonding, splinting's there, she's comfortable, nothing's moving, everything's together, endo's finished, small post hole, but no post right now. I'm not, again, investing more time and energy into it, but I don't want to fill the canal because I may go back and want to put a post in. So I'm just filling it up with some Teflon tape and just closing up the access hole. So 5 months post-op. What do you see here?
Movement.
Moving, right? Number 8's moving down. June 1st, that's for 2 months. That's 6 months. I finally got a wire in there. And that's almost a year, 9 months. All right, so now everything's stable. There's no PAP. She's like, doc, I'm going to get married. I'm like, I really want to do my smile. What do you think? And I'm like, I'm a little bit worried about doing your smile. Things are kind of not really, please. This is the sucker conversation. Oh, come on, doc, you're the best. Come on, you can do it. I'm like, sucker. No, don't do it. March, I did it. So I got her back in. I took a photo. I gave her a preview. This is a small preview. It's 5 minutes, really quick. We do this all the time in the office just to get them an idea what they're going to look like. So she's like, oh my God, I love it. It's perfect. It's the color I want. Now, class 2s, you got to have this disclosure. When they're at class 1 and in a nice position, you just want to change color, that's great. When they're at class 2, they're forward, right? They're bucky already. So that's the danger point on a class 2 patient for aesthetics. They want nice white teeth and you're not bringing out the arch. Her arch is out already. So you got to really prepare actually further than you think rather than minimal prep. It's not a minimal prep. You got to prep it back because you got to wind up where she is, if not a little bit further back because she's already bucky, right? So you don't want to add material and get a really, bad position. And it happened to my provisionals. I'll show you the provisionals. So when you talk about aesthetics now we're back in the aesthetic world. These are our parameters: facial midline, lip support, occlusion, tooth morphology. Tooth morphology means people get lost with this tooth morphology stuff. So if you have a tooth that you like, I always look at the patient's teeth and I say, which tooth do you like? So if we go back a second, which tooth do you like? Which tooth do you like? 8 or 9? 10. 10's too small. 7's okay. 8 I think is a little long for her face. So I'm going to go with 9. Right? And again, it's aesthetic. It's personal. But I want you to look at the morphology of the tooth. And if that's the tooth you like, well, I'm going to copy that. Do I need to change the zenith and make it taller? Not really. Do I want to make it longer? That's changing morphology. If the teeth are gummy smile, right, there's a lot of gums here, I'm going to change the morphology and I'm going to change the anterior position to change the morphology of the tooth. You got to do this with your fingers and your hands and your eyes. So you can envision, and then you could try it out. You could put Flowable on her teeth and say, do I think that looks better? Then take it away, and then add, take it away. That's testing the system so that your brain starts seeing what's really, really beautiful for her. Is it the exact same size tooth, don't change the morphology? Or am I changing the morphology? So when I say tooth morphology, it could be 20 different morphologies. Here's the good news. It's a finite number. In the digital files of Smile Design now that we're doing with digitally, there's a finite number of styles. When you were young and you were in dental school, they gave you this book, IPN teeth, and you're like, oh, I don't know what this is. 21E, 21F, you have to buy a tooth every time you trying in something ridiculous. Now you have things in tooth that you can try in, put it on the mouth, take a look. You want it longer? Do you want it shorter? If you're not sure, ask what she likes. So tooth morphology is a big deal to figure out, where do I want the teeth to look like? I like the preview. It gives me an idea from my own brain to see what I like. So is that the morphology that I like? Does she like what I like? By the way, when we do smile previews and the patient looks at it and says, oh, that doesn't look real, that's a problem. If she looks at it and says, oh, that doesn't look like me, that's a problem. That's a personal viewpoint from her standpoint, and that means she does not like what I think looks good.
Tomatoes left. This is
Most
green
people
tomato.
should say,
You think that's
wow,
enough
looks
salad?
great. So if you don't get a good response from something like this,
Well, so what
that's probably a patient I don't want to treat. Because she's seeing something that I don't like. What do you mean you don't like it? She says I don't like the color, I could bring the color down. But if she says I don't like that smile, I think it looks pretty decent. It's not perfect, but it looks pretty good, better than what she looked like. So if they don't accept that as what I think looks good, probably not going to treat that patient. Because that means they're seeing something else that I can't probably figure out. So tooth morphology, gingival, yeah.
When you talk about aesthetics, if they come to you wanting a better smile, the initial reaction isn't
Ice is in Sarasota. They're
positive,
staging.
they're not like super excited.
So
Are you
whoever
still
you know
trying to
needs
find that
her.
middle ground? Are you still
Even if
trying
they
to
are
find
illegal.
something that they
Because
like,
this
or when
entire
you like
situation
give up and be
for
like,
me
you know,
is
I might not be good at this.
Okay, so usually it's going to be the first reaction, and I'm going to see a negative. I'm going to see this. What do you think of this? And they don't say anything. Like, they're quiet. That's a bad sign. If they give me something like, oh, I don't like that. Now, at least I know they definitely don't like that, right? Because they weren't thinking about it. They just said, I don't like it. If they say I like it, then I'm good. But if they start thinking about it, that means they're not sure. So now that's a signal to me psychologically that I have to show them something else. Then I'll go to the other way. Instead of showing them their face, I show them 3-4 smiles that I think look good. And I'll look at different colors. I'll say like A1, B1, and OM3. So I'll show them, what about these smiles? You're not sure about what I just did. What about these 3 smiles? Oh, I really like that. I got a response. That's good. If I show them 3 beautiful smiles and she's still like this, probably not going to be good. Because I've already got 2 now. That's 2 hoops. She didn't go in. She's like, no. So that's psychology, right? Now if she says no to that, I'll go to the next one. Befores and afters, like this. I'll just show her this. What about this? Oh, I don't know. That's too wide and doesn't really fit her. That's 0 for 3. It's 3 strikeouts, right? So that's how I'm doing it, realistic. That's your psychology. So if she strikes out on 3, I'm probably not going to treat her.
But I think more and more patients are aware of like smiles and they start researching it. What if they start telling you, oh, I like it, but that distal angle and that lateral, I don't quite like that.
You're in trouble.
Thank you, though. I appreciate it.
You're in trouble. And when you put it in their mouth, you're really going to be in trouble. It's happened to me. I made the mistakes. We all made that mistake. She seems so sweet. She's my friend's wife, but she's nuts. She has psychological problems that I can't cure. It's evident. You don't like this? As a general person, like, oh, wow, that looks good. I'm not telling you have to love it, but it looks pretty good. So if there's no reality there, you're going to lose. You're going to lose. So the more befores and afters you can show them, the more psychology you're getting, more information. And usually if they go into one or two, okay, and then they like that before and after, then I'm like, maybe I could talk, but I'm already like off. If you don't like the preview, I'm already cut at 90%. I'm like, what am I going to try to convince her? If you don't say wow right away, you got something going on.
What about doing a mock-up directly in the mouth?
Yeah, but now I got to spend an hour for that. So unless she paid a lot of money for that, I don't want to waste my time. Again, in my early career, yeah, do it. Your level, yeah, sit there for an hour. You have nothing to do. Just go ahead and you're doing nothing. You're not busy. Just go ahead and do 9 mock-ups if you want. It's actually a great lesson for you. Do one on this side, you make this one light longer, and make this side shorter. No, absolutely. And at first 10 years, do whatever you got to do to get them to say, wow, that's awesome. I love that. You got to get that response, though. Whatever that is, you got to get that response. Oh, I love that. That's really great. Okay. We can work with that. I can work with that. But if you're getting no, forget it. Oh, no, I'm very honest. I said, listen, I'm sorry, Joanne, I showed you didn't like that, you don't like my before. I don't think this is the right place for you. I'm not the right person. I don't know. Now, the worst thing is when they're nice, say yes, and put the temps in, and then they go crazy. They gave you the money already. Now you're that's bad. Now you got to make a decision. I made that decision. Her name is Natalie. I can't forget her name. Natalie, here's the check, $48,000. She's like, what are you doing? I said, I can't make you happy. I did 5 temps. It's been 5 hours on temps. I don't think this is working. Just take the money back. It's fine. Go somewhere else. No, I want you to finish everything. I'm like, please, just take the money. I don't want to do this. It's torture. Happens with ortho too. My kid's teeth is not the same size on the left side. They come from England, and all of a sudden they want perfect teeth. They want perfect teeth. You're the best orthodontist. I thought the left side would be exactly like the right side. What's wrong with you, Doc?
You want to minimize the collaboration.
Right.
Those type of
No, but I'm saying for them, just go ahead, have fun.
If they do the case, the patient say, well, let's look again. I feel like we should make it.
They have all the time in the world. Let them spend it.
It's the heart.
No, because you know what? I learned a lot from that. When in my early years, I did it over and I did it over, and it was okay. I learned from that. Yes, you get to point when your aesthetic level can be higher than the patient's. That's a great thing. When in the beginning, theirs is higher than yours. You have to accept that. They're 45, 50 years old. They have $20 million. I think they know more than you. And whatever they're saying that they do. So learn from them. Try to get it up there. Yes.
Just quickly, I asked my friend, she's a pediatric dentist in the city, about the 10-year-old front teeth. She said, you do a pulp. So if the apex is open and the nerve is exposed, you do a pulp cap, which is nowadays called vital pulp therapy.
Okay.
With like MTA, like there's
MTA, right. Right. That's what I remember. Right.
And then,
Right.
a lot of time.
And let the healing grow. Yeah. Remember, their stem cells are pretty fast. 10-year-old stem cells are going really fast. Look at her protrusive position.
You go over the protocol for freehand mock-ups?
Freehand mock-ups. Let's do it one-on-one. Let's do that one-on-one. That's a long discussion. But it's basically flowable. Putting flowable on it and just trying to create a tooth. But look at her protrusive. I can't leave her like that. I got to take that enameloplasty there. That's a problem. Right? So that's her position there. That's her occlusive position. She's a class 2. So this is February. This is almost a year later. In position. We're going to prep the case. Now, look at the prep on the top. That's the starting point. Occlusal prep looks good. But this, I would say this is a mistake. Number 9 is a mistake. I didn't cut it back. I was being too gentle. I should have cut it all the way back, like number 9 was. Doesn't happen in the final, but realistically, if you look at the temps, here's the dentin shade. Here's my first temp. Here's my second temp. Here's my third temp. All right, so you see that number 9's coming out a little bit too far. And then when I take the facial photo, you can definitely see it's too far out. So again, looking back 5 years ago, I'm like, oh my God, that should be all the way back. That should be all the way back. the final turned out really good. But the point is, your provisionals are going to be directly related to your prep. You got to see that. Take that picture and see it. I didn't see it. Obviously, I was either too busy or whatever I was doing. That should have been further back, an even plane. So this is March 22. This is almost a year later. Insert the case. This is 2-week post-op from behind. You look at the bite. I've just shaved the bite down, so now all the teeth are hitting and protrusive. Looks pretty good. 3 weeks post-op. Looking pretty good. Okay. Aesthetics look good. Now it's June. Doing pretty good. Very happy. Super smiles.
Did you have any pain during the process?
It was painful, but it was well worth it at the end.
What was the best part about the whole procedure?
Definitely the end result and, coming out with this great smile.
What did your friends say, your family say?
They were like, I'm gonna get those choppers too.
That's awesome. Thank you.
All right, so we wind up there. Pretty good before and after, but 1 year after accident, what happened?
Teeth started moving.
She doesn't say anything. She just comes in for a pose. I take a picture. I'm like, oh no. What's happening?
Moving.
Teeth are moving. It looks okay on this view, but look at that. So I'm like, look, Christina, I think your teeth are shifting a little bit. I'm going to let it go. We can put a retainer on, or we can just let it go, let it open, and then we'll redo 8 and 9. Now, since this time, I have a new protocol. When this happens, or accident patients, I'll do 2 veneers, 8 and 9, with a veneer that's connected. 2 veneers connected now. So it's like a veneer connected bridge, so to speak. Very passive. You can't have it moving because it'll crack. But the preps are a little bit more off tapered, and it goes in, and they never separate. That's my new protocol from this case. She didn't let me redo it. She's still walking around with the space. She says it gives her character. I called her. She's in Korea now with her husband. She's like, I'm going to come back. Her husband's very wealthy now. But look, she was like a little girl, 22-year-old from Astoria, married a really wealthy guy. She's traveling around the world. And she's smiling big. She's a superstar. She's a makeup artist. She does makeup for all kinds of weddings and all that. I said, Chris, come back. I got to fix it. I hate this slide. She's like, I'm okay. I'm fine. Don't worry about it. She's so relaxed. She's so chill. She's not crazy. But that's what I would do now. I would prepare that, put 2 veneers together, splinter together, and call it a day. Ask her.
I think both. I think it's the both.
Probably.
So you either do a little something to intrude the lowers even more, or think about a little bit, but otherwise it's just perpetual. It's better.
It's so small. When you have such a small defect, ortho is going to kill you because you're going to go in, you're going to bring it out. You're going to bring it in, you're going to bring it out. Invisalign, you're going to bring it in, bring it out. It's so hard to make slight changes with Invisalign because it's a macro movement, right? You put Invisalign to move the tooth over, to move the tooth back. Do micro movement, it's always going to come back. I've seen it. I try to bond the back. I've tried to bond it. It just always opens up, especially when the bite's coming forward. So it's either redo the case or leave it alone. That's where we're at.
The release that is gonna happen again after the redo.
No, if I do the redo, I'm going to splint them together, and that's where I learned this. After that, I've been doing a lot of splinting 8 and 9, 7 and 6 trauma cases. Just splint the veneers together. Beautiful. Stays on. Beautiful. Any other questions, Doc?
No.
Why are
Okay.
so beautiful?
Oh, they're not. Not all of them are beautiful. So we always do interviews. I love interviews for videos.
I mean, I would definitely off the bat recommend Dr. Dean, #1, and his team, and also you feel so amazing afterwards. It's just a life-changing thing.
The other thing we do is we do champagne popping. So whenever we do a big case like that, it's a really emotional time for them. We just pop the champagne. It's $50. They feel great. I tell the parents to come in. I tell especially when they're younger, and you have the family there. It's a wonderful thing for them, and they'll just tell people about it. So one of the things, the most crazy thing about dentistry is we have this ability, especially with trauma cases, especially with young kids, to change their life forwardly in a different way. And she posted it. I mean, again, she's a great soul. To put this in there and post that, every scar is a unique, beautiful story. I mean, who thinks like that at 23, 24 years old? Yeah.
How do you handle oral hygiene when the 8 and 9 veneers are splinted together?
We always like the proxy brush. Always use the proxy brush. Make sure the bonding or whatever's in the way, they can get the proxy brush in there. It's really hard to do floss threading. Most people don't do it, but a little thin, tiny little proxy brush, they can do at home, they can do in the car, they can do at the office. So for me, it's always proxy brush.
Can I ask you about?
Yeah.
Pass from the moment of the accident to.
A year.
First provisional.
Oh,
Because
the veneers?
without anything.
She just had bonding for a year.
That looks like she had.
It was, the bonding was placed that day. It was that day I did the endo, the day I did the splint. It was, I saw her, she had the accident in May, so I saw her in June. So it was in June that we did the treatment, bonding, splinting, endo. And then we just polished it and and maintained her and put post-ops after that. Yeah.
Around how long does that take for you for that entire procedure for 1 day?
Root canal, I don't know.
One visit, 2 visits?
Well, it's gotta be one visit. You can't go back on these cases. So one visit, half an hour, 45 minutes. Bonding, splinting, half an hour. Another bonding, another maybe 2 hours, 2.5 hours, 3 hours, whatever it takes. We have all the time in the world. No rush. This is COVID time. I was playing music. I was taking my time. It was good. But you want to give yourself time so you can take care of it. So key factors: is the tooth fractured or displaced? Is the pulp exposed? Is there mobility? How many teeth are involved? By the way, the front tooth is cracked. The other tooth needs endo, but the canine hurts. Right? You got to check all the teeth. Don't focus on the teeth that are broken. Check the other teeth. They may be hurting. The PDL maybe got hit too. So check. That's why I say splint the 6 teeth if you have to, just for safe purposes. Is the apex open or closed? And what's the age of the patient? It's a big, big question.
So going back to the splinting and oral hygiene, how much do you open the embrasure, and would you, using the Proxy brush or any of the other smaller brushes, create a black triangle with repeated use?
I have 28 crowns. I use my proper toothpick every day. I have no black spaces. The reason the black space happens is because there's bone loss. Doesn't happen because you're cleaning. That's a misnomer. If I keep doing the proxy brush, I'm going to get a black space. No. If you lost bone, you're going to get a black space. My experience. I do proxy brushes on implants, on anterior veneers all the time. The bone's there. Tissue's going to come right back. I'll actually cut in to make sure there's no cement, right? I don't want cement there. I'm not worried about black space between 2 teeth that have good bone. It's going to grow right back. That's understanding tissue management and biology. If you see a perio patient and the tissue happens to be there, now you disturb it, you're going to get a black space because you lost the bone anyway. So on a young patient like that, 22 years old, I'm not worried about a black space. She was 45, 50, yeah, I guess I would worry about it, but I'm still going to open it up to get the proxy brush in. I got to do that.
So a corollary, these teeth that are traumatized, they are treated endodontically, and what's the likelihood that they're going to have some level of resorption in the future?
So I just looked that up on ChatGPT, and then I have my own little research people that I asked. It seems to be about, for the age of the patient, I'm trying to remember what I wrote. It's if it's a perforated resorption, it's got like an 80% chance of failure. It's perforated resorption. If it's non-perforated resorption and they treat it really quickly, it has a higher success rate, so they have 40% chance of failure. But you're in between 40 and 80% of losing the tooth. Internal resorption, and then I have an anecdotal. I think I have an anecdotal slide. Maybe it's the next slide. Yep, anecdotal slide. Perfect timing. 78% of non-perfect injuries. In my cases, 178 that I've been tracking for 35 years, for non-perforated internal resorption remained. 24% remained. So 75% got lost, extracted over time. Treated once with endo, treated a second time with MTA, lost the tooth, including my hygienist, Amy. So Key points: early RCT follow-up, younger patients healer faster. Take CBCT to evaluate the bone consistently. Remember, you take a CBCT now in the accident, it's fine. Take a CBCT in a year, it's gone. Resorped. Tissue, body changes. Mrs. Jones, I don't know what your body's gonna do. It may heal and you be great, or you may start losing bone. We need to watch you every 4 or 5 months. Just put it on them. I don't know. I really don't know what's gonna happen. I'm doing everything I can to save the tooth. I wanna save the tooth as much as I can. I don't wanna take it out. People take out teeth all the time. I'll take it out, put an implant in. No, because I know aesthetically it's never gonna look right. I have a Pontic on number 10 in my mouth. I used to box, broke my teeth at 16, didn't have a temporary till I was 19. 3 years walking around with no teeth. No girlfriend, no social events, very low self-esteem. I finally got a temporary. I was like, I could smile. I lost my lateral because I kept giving it antibiotics. Another lesson I've learned: stop giving antibiotics to purulent discharge and trauma cases that have the pimple and the fistula coming out. You keep giving them antibiotics, you're killing the bone. I lost that tooth. I got a Pontic. It looks great. I don't want an implant in there. It's going to look horrible. My other I have 8 root canals. My other number 8. If you look at my X-ray, you're going to say take the tooth out. It's this big, my root. Looks like I had post-ortho when I was 10. It's this big, my root, and this root's this big. Number 9. Guess what? It doesn't hurt. There's no symptoms. There's no periapical pathology. I leave my root in. When I get to that point, I'll do another apical. I have 4 apicals so far. I started when I was 18. So I know about that. It's a mental, psychological thing. Yes.
So what grade mobility are you going to make the decision of extraction versus restoration?
Great question. So at the time of the accident, you got class 3 mobility on 8 and 9. Let's just say. You splint them, you bond them, you put them together, get the occlusion out, you come back next month, it's okay. You come back next month, 2 months, and you want to take off the splint to see, but you don't want to take off the splint. You don't really know if it's mobile. What you're going to see is the bone loss just deteriorating away 6 months. Then you're going to see the whole segment moving. It's not healing. The bone is getting lost. You're going to take the teeth out. Apical surgery is coming. I mean, the apical area is getting really bad. You got a whole thing moving. It's time to talk about a 6-unit bridge, 4-unit bridge. It's not healing. The body's not healing. But you're not going to see it move. You're going to see the whole segment moving. Unless you take off the brace 6 months later and then the teeth are moving at 3 mobility 3, you can't save those teeth. The body didn't heal. It should heal within 2 or 3 weeks. Am I right? It should be solid in 2 or 3 weeks. Right. The tissue says it. If the body can't heal, body can heal. Now, I've seen younger patients who were not, let's just say, bad hygiene patients and a lot of drinking and partying patients whose the whole mouth is diseased and they get trauma. There's no way that thing's going to work. There's just too much bacteria for that to heal. Smoking, yeah. Okay, we're done with the trauma case. I want to go on to the case presentation. This is pretty quick, but a couple of really big points on this one. 56-year-old, class 2 occlusion again, history of grinding. She says she has 2 bites. Big red alert. Big red alert. I think I have 2 bites. You actually know this? This is not a good sign. Upper bridge is 7. So I never say the bridge is ugly. I never say how your teeth, whoever did the crown is no good. I never say anything negative. I just want to know when she had it done. Oh, she came in with the lower concern of the lower. My teeth look so small. I'm so young. What happened to my teeth? I said, you're grinding your teeth away. I didn't say the upper bridge caused it. I didn't say it. I just said, how old is the bridge? If she says it's 1 or 2 or 3 years old, I'm not going to say anything. If she says it's 20 years old, I may say maybe it's time to change it when we change the lower. But she said 7 years. She goes, oh, it's 7 years. I just did it about 7 years ago. So I wasn't in the position to start telling her to redo it. I was like, okay, let's focus on what she wants to do. She wants to focus on the lower teeth. Ask about the cost, want a treatment, what wants the treatment to last? How long is it going to last? That's a lot of money. How long is it going to last? What's your answer when you say, I'm doing a crown, I'm doing 2 crowns, 10 crowns veneer. What's your answer? I got to get this straightened out with everybody. What's your answer when they say, how long is it going to last? You've only been practicing for 3 years. What are you going to say? I don't know, 20 years, I've only been practicing for 3. What's your answer? It's got to be a logical answer that people can attribute to and understand. What's your answer? It all depends on your hygiene.
Depends on a lot of things.
That's not true. You want to say something that's true. What's true? I don't know.
I have a question about doing the apicos over and over again. Sorry, that looked like it was really loud.
It is.
So you said that you yourself, I know somebody that has it's a young person dealing with a front tooth thing, and she will for decades. So you yourself, having done the apicos, I don't know how many times, 3, 4 times.
4.
4. Okay. The person I'm thinking of is at 0, but one day it'll come. On a female with a high smile line, do you worry about does it kind of make an ugly scar on the gums? Of course it depends.
Yes.
But let's say
Yes.
generally, does
Yes.
that get unbearably ugly?
No, today it's very different. So back then in the day, they would slice your gum, rip it up, my first one, get in the apico, cut it up, put amalgam in. That was 1980, right? In 1990, they'd make a smaller cut with a big scar, and they'd put composite in. In 2026, they make a cut from the vestibule up there with a releasing incision, pull the tissue back, do this procedure, and pull it back so there's no scars. So there's not a scar problem. The problem is the buccal plate, mobility, and infection. Right? So my buccal plate's gone, but I have no mobility, I have no infection. And my teeth are splinted. Can't tell, because the embrasures are nice and clean. So it's not a matter how many times can you do it, it's who's the surgeon, how careful are they? I have 4 different surgeons. They're all pretty good. I guess they did a good job because my tooth's still there.
Mm-hmm.
So, and then the other big part is biology and genetics. So you could do the same procedure on 10 people and it won't work. It works for me. So I look at the body, I look at what's happening with the patient, and I make a decision and I follow up. Follow up's the key thing. So I'm not going to tell you it works on everybody. No, everybody's body's different. And I let the patient know, I don't know how your body's going to heal. So back to the question, how long is this going to last, Dr. Dean? I said, Christine, I really don't know how long it's going to last. All I have is the research, your body, your situation, which you're grinding like crazy. I'm going to predict 7 to 10 years. A very different answer than only if you come in every 6 months and it's going to last forever. That's not true. Only if I do it's going to last forever. That's not true, right? So an honest answer is the best answer. I really don't know. I've been practicing for 3 years. I've only done 10 cases. I think I'm really good. Here's my portfolio. Usually these things last 7 to 10 years. And I preface it by saying, and they don't just fall off after 7 years. It's like a cabinet in your kitchen. That cabinet looks a little bit off. You may have to change 1 or 2. That's the truth. Tell them that. I don't know. You mean it's not going to last 20 years? I go, what do you have now that you had 20 years? You got to come back right at them. What do you have now that you had 10 years ago? Car? Watch? Bag? You girls buy bags every week. So I come back at them. Yeah, you're funny, Dr. D. So you got to come back at them. You got to come back at them. It's the truth. I'm not lying. I'm not going to don't get defensive and get dental dance. Oh, I don't know. Don't get defensive. They come at you. You got to go back. You got to have a nice answer. Be nice, professional. Say, what do you have that you had 10 years ago? Can you ask him to mute himself because I'm hearing the background? Ask him to mute.
Okay.
So the answer is, I don't know. Usually what I've heard is 7 to 10 years. We're going to watch it. I don't think your teeth are going to fall out. I'm going to do the best job I can. I have the best laboratory, and I'm going to do everything I can to make it last a long time. But you need to come in for hygiene. You need to monitor us. Let me monitor you as you're going on. And if anything breaks within 2-3 years, you don't have to pay anything. Oh, okay, got a warranty. So I've given her a good answer that I'm confident with. Okay? Now, this is the part that I need you to get, the critical thinking. If you have a patient that's a grinder, and we always talk about canine guidance occlusion, okay? And she's grinding and she's worn down her teeth. And I need to reestablish canine guided occlusion, which means I got to pick up the canine and make it taller. And then it's got to slide when she moves. That's a lot of mechanical things that I'm trying to create there. You're going to test it with the provisionals. That's going to be your testing ground. It's always my testing ground. Did the provisionals break? Come back in. I got to change the bite. The provisional chip and the bite's off. Come back. I got to figure it out with the temps before I go to finals. This is a perfect example of the lower canine is worn, and if I pick it up, which is the gray line, it's going to start guiding. But I need to change the vertical to do that. I can't grind the tooth all the way down here. There's nothing left of the canine. So without changing the vertical, I have nothing to cut. There's no tooth to cut. If I add to the canine, I got to change the vertical dimension to get the guidance to work, because she's a class 2, which is harder than the class 1s. Okay? So right away, when I'm looking at the photo, I got to look at the canine. They're all worn. How am I going to prep, without changing the vertical, how am I going to prep this tooth? There'll be nothing left. I can't stay in conformity. I got to do the whole arc. I thought I just wanted to do front 6 teeth veneers. Not with this bite. Big mistake. I don't have any money. Come on, you can do it. Just do 6. It's okay. Give you 6,000. Come on. Okay, 6,000. Oh, no. 6,000. No. You gotta stop that. You gotta think. I'd rather you do it for free and do the whole arch and learn something than get the 6,000, do 6 teeth, and become a disaster, because that's not gonna last at all. Your temps are gonna break. The prep's gonna be off. She's gonna be in pain. You're gonna be miserable. I cannot do it. There's no way you can do it. Once you change the vertical, now you're free. Your prep changes, because now whatever position you're seeing her, this is her rest position. Whatever position you're seeing, now just add. Look, add. Easy. 2-3 millimeters. You got a new vertical dimension. You got great guidance. Yeah, that case is going to last a long time. She's still going to grind. How do you know she's going to stop grinding? Will she stop grinding because you changed the vertical? Big question. This is a ChatGPT question that doesn't know the answer. I've asked it. If I change the vertical dimension of a patient 4 millimeters, will the patient still grind? Ask ChatGPT. I'm going to give you a stupid answer from 1971 articles. The answer is, I don't know. That's the truth. Sometimes they do, sometimes they don't. How do I know if they're going to still grind? When do you know that they're still grinding? After what point that you finished do you know that she's still grinding? That's the worst case scenario. You want to find out a little bit before that.
If you have a patient grinding, how long would you normally keep them in temps for, so that you know that everything's kind of adjusted and you're seeing them?
It's not how long I'm going to keep it in temps, are the temps working? The temps are working in 3 weeks, I'm good to go. Temps break the first week, got to repair them. They break again the second week, I got to repair them. They break the third week, I need a lot of time for her. I don't have it together. I don't have it. 3 weeks is plenty. 4 weeks, yeah. So if nothing's breaking, good to go, because you figured it out. What does figuring it out mean? That means that when you finally put the provisionals on, the 18, 19, 20, 21, 28, 29, 30, 30, they're all hitting. Can you hear that on the Zoom? They're all hitting. And then they're guiding left and right. Now I got her in the right position. Now nothing's breaking. So the position, as you change that height of that canine, now you're getting a steeper incline of the tooth. I'll give you a little bit more demographic. If you don't change the vertical here, you can't do it. Just can't do the case. So as I change the vertical, what happens to the lower jaw? It lowers, right? Goes to this position, right? I'm going to add that. The line is where it used to be. So I've opened it, and then I've added the tooth. That's assuming, big assumption, that the upper tooth is okay. What do we have in this case? The upper teeth are old, ugly crowns. So if I'm trying to make beautiful lower teeth to a bad bridge that's like big and bulky and cause the actual wear of the teeth, a iatrogenic crown caused wearing plus her grinding, I have to change the anatomy of that tooth. I have to physically grind away the bridge on top to get the tooth to go higher. Do you understand that concept? Everybody get that concept or not really? I've changed the vertical. If I stay with what she has, I'm going to go here. If I curve it, I get a better guidance. Because I changed the anatomy of the canine. And you could do it with a natural tooth. You could do it with an old crown. You could do it with an old bridge. Change the environment to get to where you need to be for your restoration to look beautiful. When I'm doing a case, I'm changing everything around so my case looks great. So when you look in the mirror, like, you don't want to say, oh, why'd you happen to this tooth? Oh, well, your upper was really thick, so I really put it there, and that's the way it's got to be. No, change it. Change it. Change the environment. So the worn OBD is there. The restored OBD is there. And now I got a nice clearance for that guidance position. Make sense? Okay. Yes.
Tip on how to approach, because I'm assuming the patient will realize that you have to adjust the bridge.
I let him know. What's the conversation? Christine, listen. While I'm doing this temporary, I'm going to be adjusting your upper teeth because they're really, really thick and heavy, and I got to really take it down to get a good position, like a gear of a car. This is a bad gear. I'm trying to meet the good gear in the bad, and I got to just adjust a couple. You're going to hear me grinding a couple things up top. It's me trying to fit everything together. I want to make everything fit. That's the problem. And they're like, okay. Or sometimes they say, I don't want you touching my upper teeth. And then I go like this. I do like a little drama. They're getting drama. I get drama. I go, Christine, I can't do this without that. You're asking me to put cabinets in, and there's a beam over there. I got to get rid of the beam. Oh, okay. You got to put things in their world. Kitchen, cars, bags, shoes, pumps, whatever it is. Yes.
So you work out your provisionals, nothing is breaking, the occlusion is good, the aesthetics are good. You get the case back from the laboratory and things are slightly off.
Yep.
The vertical dimension is not exactly the same. The appearance, not exactly the same. What level should we have our expectations on what we get back from the laboratory versus what we've worked out in the mouth?
Okay, so the question really is, how much responsibility is the dentist and how much responsibility is the lab tech? You got out 4, 5 years, 6 years. You don't know a lot. So your expectations, you don't know a lot. What I'm telling you is learn a lot, go to CE, get some knowledge, because what happens is the more information you give the technician, the less he has to think. I don't want him making decisions, but I don't know what to tell him. Okay, couple things I could tell you right away. A video of your temps. Take a video of that canine that you just built up beautifully. Take a measurement of the video of the canine that you just said and say, hey, I just changed the guidance here and my canine's about 11.2. Please give me an 11.2 canine. Because if he gives you a 10 millimeter, it's not going to guide. And you did all that for nothing. Video, camera, movement, the way he moves left and right. Check the temps over 2 or 3 weeks. Make sure nothing's breaking. If something's breaking, you got to reevaluate. What did I do? Did I put not too much pressure on the canine? So videos, measurements. Measure the video before you start. It's like 8:15. Measure the video on both sides after you're finished with your temps and that you like them and she likes them. Now I'm at 18.5. Send that measure. So how much information can I give him so he doesn't make a mistake? Today, if I get something back that's off after I've given you all the information, dude, I'm going to kill you. Right? I'm going to be upset. It doesn't happen to me that often. It happens, not that often. I got a color back 2 weeks ago. What is this? I gave you all these photos. How did you mess it up? I'm sorry, Dr. Dean. I didn't read it right. Okay, redo the case. I didn't like to put it in. When we do cases, they're all on my desk the day before. I look at every case. There's no way she wanted OM3. She wanted A1. What the hell's going on? So I sent the case back. Hi, sorry, got to cancel your appointment. Something's not right. So I'm checking everything before they come in. I don't want a patient to come in and then I find out, wait, where's the lateral? Right? No good. So I'm doing everything on my part so that I don't get any surprises. Again, at your level, you're not thinking about all these crazy things to prevent that from happening. But that's a real deal in your first 10 years. You're going to say, I want the crown to look like that and my guidance to look perfect, and they give you something else. because you didn't give them the information, you didn't give them the video, you didn't give them the information, so they're just making a tooth. They don't know all the time you spend 3 hours on your temps. They're just making teeth. So there's got to be more communication. And it's a tough case, like this is not an easy case, but you got to give them more information. So again, visualizing the final tooth. I'm visualizing the final tooth, 3 millimeter increase, little gingivectomy on the bottom. I'm going to start preparing the teeth. What's the preparation on this? What's the preparation on this tooth? Anybody done one of these? Not so easy. It's more of interproximal preparation. They're not touching the occlusion, we're changing the vertical. Do I make a nice regular veneer here? Do I cut the gum? I mean, it's a little bit of challenge, but basically it looks like this. It's minimal reduction on the facial, flattening out the occlusal, and then making your temp that looks like that. You're relying on adhesive dentistry here, and you're relying that the occlusion, because you've restored it, there's no pressure there. Because most people say, that's not going to work. Oh yeah, it's going to work. You got tons of enamel here. Tons of enamel. It's all adhesion dentistry. And when you have your temps, they're all splintered, so that's good. When you put your individuals in, you're going to have a lot of bond strength. Plus, you've changed the vertical, so there's no pressure down here you had before. Pressure is reduced incredibly. So the final restoration ends facially. We're bringing it forward. Remember, she's a class 2. She's in. We're bringing that out a little bit to increase her nice arch form. So here's your provisional. Okay? Here's your provisionals. Nice in position, a little bit longer, a little bit taller in the back. I got my canines up. I've taken away the upper crown, so I have good guidance in there, and I can get a good position left and right. That's 2 weeks post-op. Look at the guidance. You see it? Coming right off. The bad teeth. By the way, the canines are Pontics. See her upper canines? She's generally missing canines. So that's a bridge going all the way across. Protrusive position, there's no posterior contacts when you're going left and right. And then you're sitting there with your high-tech paper, measuring everything. But your artist fall has got to be on target. And your red paper too, and your blue paper. So aesthetic smile design, when you look at the real kind of like overview, you have color, texture, proportion, position to give themselves something that makes sense. A lot of it has to do with occlusion. You've heard the term form follows function. Well, you gotta get the occlusion, but when we do provisionals and we're working with my partners, I'm like, get the bite right, get the centric right, get the guidance, then we'll do aesthetics. Because if the guidance is off, it's gonna change the aesthetic. You can't just do aesthetics first, it looks great. Close, oh, they're not closing. Well, I gotta raise this tooth and raise, now you're back to occlusion. You're changing from morphology. Always do your occlusion first, always do your guidance, your protrusive movements, then you do your aesthetics. Now you've got your occlusal scheme of function, now you can make your nice aesthetics and work around it. So here's the final, goes in. Position's nice, clean, vertical's changed. What do you think she said?
My offers.
Absolutely. I didn't have to say anything. She was like, wow, that looks like teeth. Look at what she has and look what I did. It's nothing that hard. You guys can do the same thing. You can take impression to get the same result that I got. And she's gonna look at it and say, wow, that's the way teeth's supposed to look. She's like, comes back for post-op. I always bring them back like 2 days, 3 days. So what's going on? How did your husband like everything like? You gotta find out about their family. Divorce, partners, whatever, kids, whatever. How'd the kids like it? How'd your grandmother, whatever. Oh my God, it feels so good. My bite's on target. I feel my bite, right? She knows I spent time making sure everything was hitting. Crazy. My loops and my artist fall, every tooth is hitting exactly in that position. And my guidance is free. She never had that before. It's like a bite plate. Think about a bite plate. What do you do with a bite plate? Put it in, make sure all the teeth are hitting, tap, 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 and guiding left and right. If you think about your prosthetics and your temps like a bite plate, you're never gonna make a mistake. You can't have one tooth not hitting. Cannot have. No good. Cannot leave the office. Every tooth's gotta hit. Guide right, guide left, guide position. If you can do that in every case, you're gonna be golden, because that's what the body wants. That's what it wants. The brain needs that to hit it. You can't have two teeth not hitting. People come in, oh, let me check. Can you check my teeth? Can I check my case? Yeah, let me take a look.
To wash potato.
2 teeth that aren't hitting.
No.
Oh, but the porcelain wasn't all the way up.
It's like eating
I
dirt
just put
when
it
you're a
in.
little kid.
No,
Then you don't get sick
can't.
'cause your immune
No
system's
good.
prepared.
Send it back. Add. But I cemented it already. Take it off. Make bonding on the top.
I think
Something's
it's
got to hit. You can put bonding on top. I don't care. If you're missing it by 20 microns, put bonding on the top too. Got to get it to hit when
Oh
they
my
leave the
God.
office. Temps and
ICE
finals.
admitted
Take
to
off the upper T. She's missing it.
accidentally
She
deporting a student
got
from Babson.
laterals. What happened to the temp?
Oh.
Uh-oh.
What do you mean,
My temp didn't hold. Should I put a wire and make it stronger? Or should I put the temp back and work out the occlusion? Because most people put a wire, really snap it in there, or tighten it up. No. Put back your temp, bond it in. Let's see what happens. She breaks it again, I have a problem. So she broke it. I go back, I check it again. And then I finally insert the 3-unit bridge, anterior 2 teeth, guidance right, guidance left. Pontic site looks great. Into the tissue. Cut the tissue into the tissue. So the pontic is into the tissue. It's called ovate pontic. So it looks like a real tooth. Can't just slap it on with a space. You can't have spaces on your pontics. We got a pretty good situation. Now, here's what the crazy thing about Christine is. 22 years post-op. This is 22 years old. Anybody want to take a guess at what happened? She's still grinding. She doesn't want to wear a biplate. Doesn't want to wear a biplate. And I warned her about it. What's going to happen over time, 22 years of a grinder? What's going to wear away? The canines are going to wear away. Sure enough, the canine wore away. She hits the premolar, pops the premolar off the 3-unit bridge. She had a 3-unit bridge. Have to redo that 3-unit bridge. 50% cost, five years out. I charge 50%. She's a very nice patient. Then she loses number 31. Cracks the tooth right down the middle, non-vital tooth. Take it out, put an implant in, abutment, crown. Then she loses 30. Cracked tooth, extraction, implant number 30. This is over 18, 20 years. Breaks number 18. Cracks, take it out, implants. You got implant 18, implant 30, 31 right now. Breaks the Emax crown on number 31. 2 years later, make a new PFM. I changed it from Emax to PFM. That's fine. Breaks the canine on this 2 years ago.
Excuse me.
What happened to her lower teeth? She collapsed again. I said, Christine, you're breaking all the teeth again. You're back to where you were. What do I have to do, Dr. Dean? I said, you got to redo the lowers. It's 22 years. She's like, okay, let's just redo the lowers. Redid the lowers. I gave her 20% off. Great patient, no problem. Just put her back up. Are you going to wear the biplate? No, I'm not wearing the biplate. See you in 20 years. Stuff happens. Things happen. You're not perfect. We wish. We prayed it would just stay the way we put it in.
Unfortunately, so when I'm
Just pray about that. Most of the time it does, surprisingly enough. Okay, Motivation 2026. The pictures that you see here are people's who, some crazy way, whatever their path was when they started, it went a totally 180-degree direction. Some of them I met in residency. Some of them I met 30 years after they've been practicing. He's in the back of the room. I said, what do you want to do in my class? I've been practicing for 30 years. What am I going to teach you? He stayed. How long you been with us?
Oh, I'm sorry.
He's shutting me out already.
No, I was answering a question on the chat.
When you came to FMR, how many years were you practicing?
30.
Do you know what it's like as a teacher when a doctor's been practicing 30 years and sitting in front of you looking at you? Did I say that okay? He's like, Dr. Dean, you don't have to worry about me. I'm here to learn. So first I thought he was, little. But I found out he really loves to learn. He's a student of education. And that's, for me, was the biggest inspiration, that this gentleman from Philadelphia wants to come to New York and learn. Not only did he learn, he just really took over FMR as a helper, as a director, an educational, he's like my Plato. I play dough.
Tender, oily.
Ellen, some of you know her, and Bridget, I connected them together. They both came to me on separate occasions looking for a different way of life. They've both had toxic relationships in their dental practices, like really bad. And they're crying to me at a lunch meeting separately. They didn't even know each other. And I said, you guys should get together. You really should. Let's have a meeting together. So they met. She got on board. It's a whole story. You've seen their Instagram. They're amazingly successful. I don't know. I have this kind of knack. You know me since she was my student, by the way, in undergrad. I was prosto. She was A+, like top of. Are you number 3 in the class?
1, 4, 2.
She was so smart. I said, you don't want to be pros. She's like, ortho. You guys are crazy. I'm going to do ortho. Olga's another one. So what I'm saying is, you're in these seats listening, you're at home listening, and it's a matter of where you want to go. So every year I put a motivational group together. I didn't have a chance this year because of personal things that I was going through, but I wanted to give you 20 minutes of what I think 2026 should be, especially for the younger dentist. You got to get a book. Every year I get a book. 2020.